We'll begin.
So I'm continuing, I'm sharing the screen, all right?
Manasi? Where is she?
Sorry, I was just doing the YouTube live. Yes.
Should I share?
Hello? Yes, you can start sharing, Dr. Chaudhary. My screen will stop automatically.
Right.
Very nice.
Okay.
So, good evening, everybody. We are here for the third and the last module for neuroinfections. And while I was going through the set of questions, these two particularly caught my mind. I'm sure everybody must have understood why I picked them up. Interleukins obviously is a favorite at the moment, and so is bioterrorism in the light of this epidemic. And I did think that, like I thought, if examiners also cast an eye on these two topics, they may also consider these as contemporary issues running on. And so we've chosen this. Also, there's not much literature you would find in books. So Dr. Chaudhary has taken a lot of efforts to prepare on this particular peculiar area, which is asked, interleukins in CNS infections. I request him to enlighten us. To Dr. Chaudhary.
Very good evening to all the audience. I'll be talking about interleukins in CNS infections, and as already told to you all by Dr. Shripad, that it's not a very common topic which we'll find in the literature, both on the net and in the books. So what I have tried to do is we have all learned about interleukins in our microbiology, in our pathology, in our immunology. And we always, I'm sure that most of us found it to be real jargon if we try to read about each and every interleukins that are present in the body, along with their functions, their sources, their targets. So what I've tried to do is, why are we talking about these interleukins and cytokines, particularly in CNS infections, and how relevant it is to us in our daily practice? So we know that cytokines, which includes soluble polypeptides and interleukins, there are other kinds of cytokines also, which are like growth factors. There are some, there are other molecules which are acting on the different cells in the body. They all play an important role in the pathogenesis of infection. And they all have multiple cellular sources and targets. And it is really difficult to learn all the sources of each and every interleukins and possibly learn all the targets of each and every interleukins, because it's a complex, intricate network which works in tandem to bring out a certain result. So it is not a particular interleukin which is acting on a particular, just like a plexus of nerves which is we are supplied in our body in neurology. So they are formed by different roots and they ultimately come out with different nerves. Similarly, there are various sources of a particular interleukin, and there are various interleukins which actually work together to work on the target. They all modulate the levels and effects of each other. They have both biofeedback, in which one increases the levels, certain interleukins decreases the levels of other interleukins. So it's not a very 1 + 1 is not 2 here. It is a complex twined between each and every cellular targets and sources. And we all know that these cytokines at the inflammatory site may be a better indicator of severity in CNS infection, which I'll be elaborating in the further slides. Interleukins or cytokines actually are already present in a normal human being, and they do help in normal CNS function. So there are functions like regulation of sleep, variety of neuroendocrine functions. When we are in a growing stage, it also helps in neuronal development, like the cytokines like nerve growth factor and brain derived neurotrophic factor. They have certain roles in brain aging. We all once there was a pathological study done where they found that interleukin 1 receptors were found normally in many parts of the brain, which included the dentate gyrus, the hypothalamus, the cerebellum. However, there was a certain scientist who suggested that the cytokines in the brain are compartmentalized, which are present in normal CNS functions, and there are certain interleukins or cytokines which are increased whenever there is a either a peripheral or a local immune stimuli. Normally, the cytokines which are present in the peripheral blood, they do not cross the blood-brain barrier. However, they can sometimes we all know the leaky areas of the brain. There are 3 or 4 leaky areas in the brain where the blood-brain barrier is compromised in a normal individual. And the organism, the organum vasculosum of lamina terminalis, it's the most common site where the cytokines from periphery, can cross the blood-brain barrier even in normal individuals. The central nervous system, it's actually immunologically privileged site, and it behaves differently from all the other organs present in a body. Why so? So once we try to find out, the reasons are that it is devoid of any lymphatic system that captures the antigens, just like in the peripheral blood. It is protected from the circulating blood by the blood-brain barrier, and it is permeable to soluble substances, including immunoglobulins and growth factors. Now, there are cells of the CNS, which include the neurons, which includes the macroglia. The macroglia comprises of different cells like the astrocytes, the oligodendrocytes, and the ependymal cells. And there are the, phagocytes like microglia. All these cells in the CNS, they are not, as immunologically competent as the other cells in the body, because they have a low expression of the major histocompatibility complex 1 and 2. However, in injury or any pathological events in CNS, there's a breakdown of this blood-brain barrier. In normal CNS normal CNS and a normal situation, there is a very low level of expression of the inflammatory cytokines. As I had already elucidated that it has been compartmentalized into the normal cytokines, which is required for normal function, and the other compartment where it is increased in the pathological states. This plays at a very low level, and there's always, even if when it plays at a low level, there's always a balance maintained between the pro-inflammatory cytokines and the anti-inflammatory cytokines. Once we look at the left-hand side of our screen, we find that the cytokines which are needed for protection in cell survival include the interleukin 4, the interleukin 10, the nerve growth factor, and the insulin-like growth factor. However, the pro-inflammatory cytokines includes the interleukin 1, the tumor necrosis factor alpha, and the interleukin 12. So there is a very fine balance that is maintained in the normal brain, even if it is, some cells cross the blood-brain barrier. We see that these interleukins not only increases in situ CNS infections. However, there are diseases like septic encephalopathy, where peripheral sepsis also causes some changes in the CNS and responses in the CNS. So this peripheral inflammatory signal transmits to the brain, and thus we have increase in certain cytokines in patients who are in sepsis, thus leading to septic encephalopathy. There's a detection of peripheral immune response, and this occurs specifically via vagal afferent circumventricular organs, and directly they signal at the blood-brain barrier. There was a scientist from Philadelphia who had proposed that peripheral immune message to the brain is mediated primarily by the sensory nerves rather than by blood-borne mediators. So how does it occur? Actually, there is a signaling at the blood-brain barrier, and the endothelium and the perivascular cells synthesize prostaglandins, and there is hypothalamic response causing fever. There's also a concept that any peripheral inflammation causes a mirror inflammatory response in the CNS. And the cytokines ultimately produced in the brain can be from several sources, including the 3 types of macroglias and the microglias, and the inflammatory cells which might have crossed the blood-brain barrier, the microvasculature in the brain, and the choroid plexus and the astrocytes. Having said that, and having understood that there are both normal presence of interleukins, which helps in normal functions of the CNS, there are interleukins which increases in peripheral immune response in sepsis. There are interleukins which are also increased when there is in situ CNS infections. So it is worthwhile to note the detailed, sources and targets of 3 important interleukins in the CNS. That includes interleukin 6, interleukin 8, and TNF alpha. So the interleukin 6 is produced by the monocytes and macrophages, and they work synergistically with interleukin 1 to actually promote B cell growth and has a wide variety of biological activities, which include fever, and it is a induction of acute phase response of inflammation. The interleukin 8, which is also called the monocyte derived neutrophil chemotactic factor, they are the potent chemoattractant. They have a potent chemoattractant effect on the neutrophils, and they leads to some upregulation of adhesion receptors in the neutrophils. The third interleukin I was talking about is the tumor necrosis factor alpha, which is also called cachectin, and it has important role in modulating the endothelial cell functions. All in all, we have to remember that these three interleukins are important in bacterial meningitis primarily, because there was a study which was done in China. I would be coming to that study and would be showing in my further future slides. We also see that macrophages are a uniquely rich sources of interleukin 6, 8, and TNF when activated. And as I've already told before also, I'm reiterating the fact that complexities of this integrated network of cytokines are just beginning to be understood. They all have roles in determining the progress of CNS inflammation. So these cytokines do not only result in the symptoms of CNS infections like fever, headache. They also have role in augmentation of seizures, because it is seen that interleukin 1 beta, they cause augmentation of seizures by upregulating the NMDA receptor mediated calcium channels in the synaptic cells. The glutamate uptake by astrocyte is also reduced by the same interleukin, and TNF alpha has also shown to affect neuronal excitability. Coming to the study I was talking about, in which the interleukin 6, 8, and TNF alpha was evaluated in patients of bacterial meningitis, aseptic meningitis, and encephalitis. This study was done in China on CSF samples obtained from 53 patients. And they found that interleukin 6, 8, and TNF alpha, all three were significantly raised in patients of bacterial meningitis more than those of aseptic or the viral meningitis. And those who were just present with parenchymal disease without the involvement of the meninges, these three interleukins, these three cytokines were not that elevated. We can clearly see that the interleukin 6 was 565 picogram per deciliter in patients of bacterial meningitis, as compared to undetectable levels in patients of encephalitis. Similarly, there was also a study done on different kinds of 4 or 5 kinds of interleukins in patients of aseptic meningitis and viral meningitis. The chief cause of viral meningitis in these children were mumps in 19 of the patients, and ecovirus in around 22 of the patients. And they compared it with 21 viral fever without CNS involvement. And they found out that interleukin 8 was raised both in the mumps and the ecovirus infections, and interferon gamma was only predominantly raised in mumps infection and not elevated in the ecovirus meningitis. Similarly, interleukin 1 receptors type 2 were elevated both in the mumps meningitis and ecovirus 30 meningitis. It's very pertinent to tell here that not only the interleukins have to work in tandem with the receptors inside the brain. So until you have receptors for a certain interleukins, that will not be able to act on its target. So interleukin 1 receptors are important subset of interleukins, which are again measured in the CSF and the blood as a marker of inflammation or any other activity in the blood or the CSF. Interleukin 1 was seen not to be raised in both the mumps and the ecovirus meningitis. Not only the bacterial and the viral meningitis, there have been studies in which they have particularly seen cytokines in tuberculous meningitis also. However, the role is still debated. The hypothesis that the cytokines is raised in tuberculous meningitis have come from the animal studies, which have shown role of interleukin 6, interleukin 1 beta, CCL21, and CXCL10 in TB meningitis. There was a study of around 140 TBM patients, which was done my alma mater, PGI Chandigarh, that occurred from 2012 to 2016. And I have the data here, which shows that interleukin 2, 6, TNF alpha, 1 beta, and interferon gamma, they all were significantly raised. Not the interleukin 2, but the other 4 interleukins were significantly raised in both serum and CSF. of TBM patients. However, interleukin-2 was only significantly raised in patients of in the CSF in patients of TB meningitis. So as per the severity of TBM, we also saw that the 5 types of interleukins, the values actually varied with the severity, and it is clearly seen that in the interleukin-2 raised, the levels raised from 68 to 87 when the severity of the disease, clinical severity changed from stage 1 to stage 3. Similarly, interleukin-1 beta also had a rise from 31.6 to 118 once we had the severity changing from stage 1 to stage 3. So all in all, we concluded that serum and CSF pro-inflammatory cytokines were they were markers of TBM, and significant positive correlation between cytokines and disease severity, which was measured with the help of Schwab and England activity of daily living scale and Glasgow outcome scale. They had a positive correlation, and particularly significantly positive correlation between TNF alpha and interleukin-1 beta, was with the presence of exudates, which is a major cause of morbidity and mortality in TBM, and highly significant correlation between all cytokines were seen with markers of CNS inflammation. There was another study done to see the levels of interleukins in patients of HIV. There were patients of HIV with CNS involvement. There were patients of HIV without CNS involvement. Those patients of HIV with CNS involvement were further divided into 2: those who had HIV-associated dementia and those who didn't have dementia. So the levels were compared, and it was seen that the patients with HIV dementia had a significant rise in TNF alpha. However, once we measured the interleukin-4, it was seen that the HIV dementia patients had undetectable levels of this interleukin. However, the same interleukin-4 was found at a very high levels in patients who had HIV with CNS involvement without dementia. So all in all, the studies are still ongoing, and we still have to do more robust studies to actually pinpoint that which interleukin exactly is exclusively a marker of certain disease. So there is a significant overlap still. However, there was a wonderful study done in Philadelphia in which they retrospectively tried to study 43 patients with using their samples and measured all the 41. There were 41 cytokines which were measured in those all 43 samples. They did the discriminant analysis, which is a statistical technique to find out which cytokines were of importance in actually differentiating patients of inflammation who were infectious and non-infectious. And similarly, using another method of statistics, which is known as the PCA plots, the informative cytokines were used for generation of 3-dimensional PCA plots. And they identified disease type clustering, to identify which cytokine would be exclusively or would be a marker of infectious or a non-infectious, pathology in the brain. Because most of the inflammatory diseases do present with fever, sometimes headaches, and similar presentations are there. So what they actually found out that if the patient had an unknown CNS disease state and they did, IP10, CXCL10, so the bracket shows the sensitivity, specificity, and the likelihood ratio of the following cytokine markers. They found out that there was a 93% sensitivity of IP10 and CXCL10 to differentiate a patient or a patient with CSF of having infection or a non-infectious etiology. Further, elucidating which type of infection, they used MDC and CCL22, and they found it useful to differentiate between a viral infection and a non-viral infection. Similarly, coming to the left arm of the algorithm, you found out that the non-infectious causes could be lymphomas or autoimmune etiology or a gliomas. And they found interleukin-8 and CXCL1 to be useful in differentiating between the neoplastic etiologies, except lymphoma, and the lymphomas and the autoimmune etiology. Further, going down the algorithm, you find that PGDF-AA was used to differentiate between autoimmune etiology and a lymphoma. However, this was a study which was done in 43 patients, and this has been proposed by them. We still need more robust studies to find out exactly that what they are proposing is applicable in our clinical practice or not before introducing them to a real life practice, because measuring the cytokines entails a lot of cost, and in a resource limited country like ours, we still need to be more sure and 100% sure whether this will help us in future or not. So not taking much time, because I had a limited time of 15 minutes. I hope I am within time. The take home points are there are certain cytokines are produced in the brain and are important for normal functioning. The CNS is an immunological privilege. However, both peripheral infections and CNS infections lead to rise in certain cytokines. In normalcy, there is a balance between the pro-inflammatory and the anti-inflammatory cytokines. And there are three important cytokines which are of greatest value in bacterial meningitis, that include interleukin 6, 8, and TNF-alpha. And studies have shown rise in levels of different cytokines in different infections. However, specificity is still debated and is a matter of research. These are the articles of interest which the students would find useful to read during the preparation. Most importantly, I have not included one article because I found it very recently, maybe 2 hours before this presentation, which had been held by Dr. Choudhary. There was an article from PLOS, which actually the last slides which I showed, where cytokines are useful in discriminating patients of infectious and non-infectious etiology. I would forward that maybe to Dr. Choudhary. Dr. Choudhary can forward it to the students. However, I would recommend all of you to read the 4th article, which was published in the Green Journal of Neurology in 1995, which has elucidated very clearly the production of cytokines in CNS, and how it is different from the cytokines in the other parts of the body. Thank you.
Excellent. I think that was superb. I mean, for such an oddball topic, you covered everything, including infections, bacterial, viral, TB, and differentiate them from tumors and non-infectious diseases. Fantastic, fantastic. So let's go on to the next one. Another area which is difficult. Today's both topics are likewise. So Dr. Amit Kumar is going to teach us on bioterrorism in neurology. And without spending a moment, I will request him to begin his lecture. Great.
Hope I'm audible.
Yes.
Yes. So good evening, everyone. Good evening, Madhu sir. I see you have logged in, and I would like to thank Dr. Sripath for this opportunity. So the topic, as we all know, the 4th paper in neurology, obviously it's a recent advances, and we find quite a different kind of questions which we are not used to. And bioterrorism in this current scenario, that is in the scenario of a pandemic, it is very important. So let's start. So in the schema, I'll be dealing it like an exam paper. So first of all, we have to know what's the definition, then what a bioweapon is, what all things can be used as a bioweapon, what is it, what is the classification, and what are the delivery methods by which bioterrorism can be initiated, then when to suspect bioterrorism, then what is the neurologist's point of view in bioterrorism, and health system response to bioterrorism. So the definition of bioterrorism, let me start with the word. There is no single universally accepted definition of bioterrorism. So the country that takes bioterrorism the most seriously, that is the United States of America. And here the CDC has put forth a definition, that is the unlawful use or threatened use of microorganism or toxin derived from living organisms to produce death or disease in human, animals, or plants. And the act is intended to create fear and intimidate governments or societies in the pursuit of political, religious, and ideological goals. So what are the key features of agents used as bioweapons? So the most, when we think about a particular thing being used as a bioweapon, we have to understand that it has to be something that can produce a high morbidity and mortality rates. The potential for person to person, like you infect a person, that person goes on to infect another. So 1 becomes 2, 2 becomes 4, and thereon. The low infectivity dose and the highly infectious aerosol method of spreading the substance, because aerosol will result in a greater spread. The lack of rapid diagnostic capability, lack of universally available effective vaccine, a potential to cause anxiety, availability of the pathogen and the feasibility of large-scale production, environmental stability, or database of prior research and development, and the potential that this particular thing can be weaponized. Now we can classify bioweapons in different ways. I will be talking about two. One is the public health impact criteria that is based upon the mortality and the morbidity that the bioweapon can cause, the delivery potential, the public perception, and the public health preparedness needs. And most importantly, it's the CDC. The CDC has classified it into type 1, 2, and 3. So what are the CDC agents as per the pathogen? That is the bacteria, the fungi, and the virus, which can be used as a bioweapon. The bacteria, among bacteria, the most commonly used bioweapons are Bacillus anthracis. As we all know, in the past, a decade earlier, America faced a major bioterrorist attack in form of envelopes with Bacillus anthracis spores, which led to an epidemic in America. Then the other being the Brucella species, the Pseudomallei and the Mallee, the Clostridium, Klebsiella bonati, the Francisella tularensis, and the rickettsial species. And among fungi, as we all know, it is very difficult to convert it into a bioweapon. So there are very few fungi which can be used as a bioweapon. And the Coccidio immitis and the Posaridaceae are the most common ones which may be used as fungi. And among viruses, it's a very big number because it can be produced and disseminated easily. And the most serious ones, which can be seen, are the Ebola, which we know that there was an epidemic. There was an outbreak of Ebola in Africa. Then Nipah, then KFD or the Cassandra forest disease, the Lassa fever, and the Marburg fever. Now going on to toxins which can be used as a bioweapon, there is aprid, then saxitoxin. There have been a lot of conspiracy theories whereby saxitoxin, which is basically sea animal based toxin, which has been used by spies as bioweapons in killing. Then there is Clostridium perfringens, the conotoxins, the Shiga toxin, and the tetrodotoxin. And additional potential bioterrorism agents, including the Chlamydia psittaci, the hantavirus, the Salmonella species, and Vibrio cholerae, has also been proposed to be used as bioweapons. Now, bioterrorism agents, potentially there are thousands, but there are a few which have been discussed in detail and tagged. And the NATO NBC handbook lists 31 agents, and the CDC created the category A, B, C, and A, B, and C list, which was loosely based on the ease of dissemination, the potential for public health impact, the potential for public panic, and social disruption. Now, going on to classification, that's the category A. Category A, biological agents or critical biological agents are those which can be easily disseminated or transmitted from person to person, can cause high mortality with potential for major public health impact, might cause public panic and social disruption, and require special action for public health preparedness. So the category agents are variola major, or the one that causes the smallpox, Bacillus anthracis, Yersinia pestis, which causes the plague, Clostridium botulinum, Francisella tularensis, the filoviruses, that's the Ebola, Marburg, Arena, Lassa, and the Junin virus. Now going on to category B, these are moderately easy to disseminate and can cause moderate morbidity and low mortality, require specific enhancements of the CDC diagnostic capacity for enhanced disease surveillance. And the category B agents are the Coxiella bonati, which results in Q fever, the Brucella species, then the glanders, then the alpha viruses, then ricin from the castor beans, then epsilon toxin of the Clostridium perfringens, and the Staphylococcus enterotoxin. Then there is a subset of list B agents, that pathogens that are food or waterborne, such as Salmonella species, Shigella dysenteriae, Escherichia coli, Vibrio cholerae, and Cryptosporidium parva. Now, there have been sporadic reports where this has been used by Janda military, those oppressors, against minority small villages, where an outbreak was caused by disseminating Salmonella or a Shigella virus, a Shigella bacteria. Now, category C, these are the emergent pathogens that could be engineered for mass dissemination in the future, or the emerging pathogens to which little or no immunity exists in the general population. And in this includes the Nipah virus, the hantavirus, tick-borne hemorrhagic fever viruses, the yellow fever, and the multi-drug resistant tuberculosis. Now, what are the biological delivery methods? Now, whenever someone thinks about a bioterrorism, they would think about a delivery method that can cause the maximum dissemination. So it may be through the food or water, aircraft sprayers, then vehicle sprayers, hand sprayers, or through mail. Now, when to suspect a bioterrorism, the key indicators which indicate that this could be a biological terror event. the occurrence of vector-borne diseases where there is no vector previously, or the cluster of sick or dead animals without a particular reason, an atypical seasonality. For example, a particular disease may happen in a season as an outbreak or an epidemic. If in an atypical season that disease occurs, always suspect this could be a foul play. Now, geographic pattern of illness and the more respiratory presentation of illness, all of these are key indicators of a biological terror event. So what to do if you suspect a bioterrorist disease? Immediately notify. That's the hospital infection control, isolation, laboratory evaluation. The hospital administration should make a decision how to test and contain. Now, what is the neurologist point of view? So there are a handful of possible bioterror substances which can present with neurological symptoms. And the most common of them are the botulinum toxin, the seafood neurotoxin, the nerve agents, the anticholinergic poisoning, cyanides, and anthrax. Let's take those one by one. So botulinum toxin, as we know, it is a very lethal kind of toxin. 1 gram of botulinum toxin would be sufficient to kill 1 million individuals if adequately dispersed. It has an incubation period of 12 to 72 hours, and the mechanism of action being preventing the intracellular fusion of acetylcholine vesicle with the motor neuron membrane, thus preventing the release of acetylcholine. The clinical presentation produces a descending symmetric flaccid paralysis, begins in the bulbar muscles, presents with multiple cranial palsies early and prominent with resulting symptoms of diplopia, dysarthria, and dysphagia. There can be mydriasis, dry mouth, and constipations, and usually they tend to have no CNS symptoms or tends to have an intact mental status. So diagnosis is basically by using a mouse bioassay or a toxin immunoassay, and the management is usually supportive, and it includes mechanical ventilation. Then we have an equine antitoxin, that is HB80. It has antibody fragments to all 7 known botulinum toxins. A single dose of antitoxin is usually adequate to neutralize any circulating toxin, and a repeat dose can be considered in case there is a chronic sustained exposure. Now, vaccine, yes, there are botulinum toxoid preparations, but they are not commonly available for general use. These are mainly for military and research establishments. Now, the seafood neurotoxin or the saxitoxins or the neosaxitoxin, the mechanism of action being a selective, reversible, voltage-gated sodium channel blocker. The onset of symptoms are minutes to hours, and the clinical presentation includes severe, rapidly ascending paralysis, common bulbar involvement, hypersalivation, diaphoresis, GI distress, anxiety, and it may result in convulsions. The paresthesias are predominant, especially start in the perioral region and spread to the lips. Now, nerve agents. Nerve agents, as we all know, notorious. The Iraqi generals use these nerve agents on the Kurdish nationals and the Iranian army. So the method of dispersal, the aerosols, the onset of symptoms is seconds to minutes and dose-dependent. Clinical features including the skeletal muscle weaknesses with fasciculation to paralysis, exocrine secretions early and prominent, salivation, lacrimation, urination, defecation, GA hypermotility, the MSS, meiosis, or rhinorrhea, we call it as the slut symptoms. And the dose-dependent, it is dose-dependent. It can result in irritability, headache, convulsions, and coma. Now, anticholinergic, such as anticholinergics, the onset of symptoms will be in minutes to hours, and the clinical presentation will be usually cutaneous vasodilation, anhidrosis, hypothermia, non-reactive mydriasis, urinary retention, and tachycardia. It will result in anxiety, agitation, confusion, delirium, hallucinations, seizure, and coma. Now, cyanides, usually they have onset in minutes. The clinical presentations including mucosal irritation, GA upset, arrhythmia, skin flushing. The pupillar light reflex will be delayed, and the patient may have headache, dizziness, drowsiness, seizures, and coma. Now, anthrax, which is one of the most, it is one of the most commonly used bioweapon, I should say, or the most used. The onset of symptoms being hours to weeks for the systemic and pulmonary manifestation. The neurological manifestation usually comes in as the second stage, and the most common neurological manifestation is the hemorrhagic meningitis. And the clinical presentation include the long track signs, hyperreflexia, myoclonus, and rigidity. Patient presents with all signs of meningitis or meningeal irritation, fever, nausea, vomiting, headache, confusion, seizure, stupor, and coma. And the most common presentation is a hemorrhagic meningitis. We describe the autopsy finding as a cardinal's cap. That means when we open up, we see an absolutely hemorrhagic meninges covering the brain. So the treatment can be divided into two. That's the post-exposure and for active disease. In case it is post-exposure, we can either use ciprofloxacin, doxycycline, or amoxicillin and we should understand that it is for 60 days, that is for 2 months. And in active diseases, we can use a combination of ciprofloxacin or doxycycline, clindamycin, or rifampicin. And antitoxins are available, but again, it is only experimental, not widely available. That is raxibacumab and obeltoxaximab may be used. And there is an anthrax vaccine at SOAP, which is a cell-free culture supernatant of the attenuated, non-encapsulated strain of the Bacillus anthracis. That's a Stern's strain. So the preparation to tackle bioterrorist attack, we should always familiarize the medical staff with the bioterrorist agents. So if at all there is a suspicion, we have to zero in on what kind of an agent may be used so that we can plan the activity, that is decreasing the exposure and managing the signs and symptoms of whatever exposure that has already happened. Then incorporate into the disaster planning, that is decontamination and infection control, communication with key agencies, laboratory, respective health authorities of the nation. Then contacts to obtain stockpile supplies and security preparations. So as we all know, we have a lot of movies where bioterrorism has been portrayed, right or wrong. Then there are other beautiful books too, such as The Plague Wars and The Dirty War, which are actually two of my favorites, which depicts how serious and how relevant bioterrorism is. And for future reference, I suggest these two articles. These articles generally cover the neuroterrorism side, the bioterrorism side of neurology very well. And the chapter in Harrison about the bioterrorism is also beautifully written. Thank you. Thank you very much.
Very nice. I think in a short span, Amit, you covered everything. Very useful lecture. I urge students to all our PGs to go through the spectrum of the lecture, which includes the organisms, the toxins, and this thing as well, the gases and the symptoms and management. Good, excellent. So let's now move on to the last part of our today's session, which is the quiz for all the lectures that we've had on infections and today's lectures as well, which will be delivered by Dr. Rahul Kulkarni. So time for revision. Without wasting time, I request him to share his slides and begin the quiz. And thank you again, Aditya and Amit, for excellent lectures today. Dr. Kulkarni? Yeah, great.
Is that visible?
Yes.
All right. So typically we'll run the quiz about the infection topics which have been covered over last 3 lectures or so, or 3 weeks or so. So I wouldn't be probably talking about something which was outside the syllabus. So I'll be sticking to the syllabus. My request is those who are using Slido or those you who wish to vote for the quiz, please open Slido. It can be in your app. The app of Slido is excellent, or you can open it on your laptop or even in the browser also, and use this code A872 capital A as for the quiz. Code is 872. So I'll be showing about 25 odd questions with answers and the explanation which was there amongst the talks which are delivered in last 3 weeks. So please join. I see only 2 names here. So those who wish to join, please join. I mean, if more and more number of people join, then probably it is a good idea to run the show. Please join slido.com. That's the website that you can join, or you can also log in, open the app. You can see the QR code and maybe it's easy for you. Please join. I see people joining. Let's wait till some more people join. I see that there are about 25 odd people who are part of it, and there are 8 who are joined here. So let's wait at least till the number goes in double digit. There are 9, 10, 11. Tell me, Shripad, when do we start? number is gone up to 11.
I think some of them may be on YouTube as well.
Yeah. No, the people who are watching,
The people who are
who joined are about 25 odd. See, you can
Yes.
see there are 30 plus people who are there, and there are 12 who are joined here.
I know.
I can see some familiar names.
To join the quiz so that then
Yes.
we can assess you and you can assess yourself really for all the topics. So it becomes very useful exercise to come to know what all you retained and whether you are able to answer, putting yourself in the position of a student.
Yes. So there are 13. So shall I start?
Yeah, we can begin.
Okay.
Some of them.
So please keep your mobile phones or the apps open. Questions will follow. There will be time given for the question. So let's start with the first question. We had a topic on SSP. So which is the preferred route of administration of interferon alpha in the patients of SSP? Is it intrathecal, intraventricular, intravenous, or intramuscular? So please vote. The 60% people have voted for intraventricular, which indeed is the correct answer. Intrathecal was a route which was there when I was doing my MD. This was 30 years back, or more than 20 years back when it was used. So initially, interferon was used as an intravenous and intrathecal therapy. It was of questionable effect, but then it was really the intraventricular which really is the therapy which is being used. So an Omer reservoir has been placed subcutaneously, and you can give intraventricular interferon. The regime is a 6 weeks course. It's like any other chemotherapy. You can give interferon and alpha starting as 1 lakh unit per meter square and increase it up to 1 million, that is 10 lakh unit meters per meter square per day for a period of 5 weeks, 5 days in a week, and you give a course for 6 weeks. You can repeat these courses maybe 6 weeks at 2 to 6 weeks interval up to 6 weeks. So that's a therapy which can be used in the patients of SSP, rather notorious or difficult therapy. Another question, please be ready. More and more people can also join. Which of the following is not seen in stage 3 of SSP? I'm sure some of you would be knowing the stages of SSP. So which of these is not seen in stage 3? Extrapyramidal symptoms, decorticate rigidity, signs of autonomic dysfunction, or myoclonus? Please vote. Okay. 46% have said myoclonus, which indeed is the correct answer. So if you go to this clinical staging of SSP, stage 1 is which runs for weeks to years. The patient may have irritability, forgetfulness, personality changes, lethargy, and poor performance in the school. But it is a stage 2 which really where the lot of movement disorders come, and the classic myoclonic jerks, as well as sometimes the long track signs would come in stage 2. In stage 3, myoclonus usually is absent. Patients usually will become rigid. They may have flaccid or decorticate rigidity. They can have autonomic dysfunction. While in stage 4, there is complete autonomic failure. Patients are vegetative, and there can be death because of the disease. So myoclonus is typically seen in stage 2, which is the hallmark of the slow myoclonus, which is the hallmark of SSP, is seen in stage 2. While in stage 3, myoclonus is usually absent. Okay. Going to the next question on SSP. This is the last question on SSP. The following are Dyken's criteria of SSP, except typical clinical presentation with progressive intellectual deterioration and myoclonus, characteristic electro EEG findings, MRI abnormalities, elevated CSF globulin, and elevated CSF measles antibody titer. Please vote. Which is not a part of Dyken's criteria. Those who attend lectures would know about this probably. Okay. 62% say parieto-occipital white matter changes on MRI, which indeed is the correct answer. The Dyken's criteria were way before MRI was there. Dyken gave these criteria probably in late 80s. The criteria said typical clinical presentation with progressive intellectual deterioration and myoclonus, characteristic EEG abnormalities, CSF showing elevated globulin levels, elevated measles antibody titer, and of course he also spoke about brain biopsy. The definitive criteria says that brain biopsy plus 3 more, or the probable would say 3 of the 5 or 3 of the 4 criteria. That's how SSP is being diagnosed if you don't do brain biopsy. Going to the next talk, quiz question. Please get ready. So anti-helminthic therapy is contraindicated in, please read the question carefully. It is contraindicated in intraventricular neurocysticercosis, subarachnoid neurocysticercosis, calcified neurocysticercosis, or cysticercal encephalitis. Please vote. Okay. So the question is, it is contraindicated in. And the contraindication usually would mean that if you use the anti-helminthic therapy, the disease would worsen. So the correct answer actually here is cysticercal encephalitis. Other 3 conditions, probably calcified neurocysticercosis, you are not going to use anti-helminthic therapy. But if you use, it is not going to cause any harm. But if you use in cysticercal encephalitis, it is a disease because of inflammation of the parenchyma due to release of antigens. So if you add anti-helminthic therapy, it would lead to sudden increase in the inflammatory mediators, leading to acute cerebral edema and maybe death. So if the patient has got cysticercal encephalitis, which is a rare entity, one should not be using or anti-helminthic therapies. It is actually contraindicated. In the rest, other conditions, probably it is not indicated, but it is not contraindicated. So it was a little tricky question. Going to the next question, again on cysticercosis. Which is the most effective therapy in the treatment of multiple neurocysticercosis? Albendazole plus steroids, praziquantel plus steroids, albendazole plus praziquantel, albendazole plus praziquantel plus steroids, all 3. Please vote. Okay, 60% people say triple therapy, while 33% say albendazole plus steroids. And the correct answer actually is the triple therapy, albendazole plus praziquantel plus steroid. Remember, we are talking here about multiple cysticerci, not about single lesion. And there is an evidence for this. It was a study done by Hugo Gracia from Peru, which is probably a center which is doing the maximum studies of multiple cysticerci. His center has a large number of patients of cysticerci. And he says that every day probably he admits at least 3 patients of neurocysticerci. So he has done large amount of work in neurocysticercosis. And he compared these 3 regimes. And then he concluded that the combination therapy with steroid plus albendazole plus praziquantel is the best therapy. So the triple therapy probably is an answer if you have multiple neurocysticercosis. Last question about cysticercosis. Get ready. Which form of neurocysticercosis can cause vasculitic infarcts? Intraventricular, parenchymal, racemose, or calcified? Relatively simple question. Please vote. Which causes strokes or infarcts? And the correct answer actually is racemose cysticercosis. Because subarachnoid neurocysticercosis can grow in enormous size, it can cause inflammation of the nearby vessel, leading to vasculitic infarcts. And the vasculitic infarcts can occur because of subarachnoid or racemose cysticercosis, seen in about 4 to 12% of the patient. And parenchymal cysticercosis does not cause infarcts. It would typically present with seizures and at times with headache, very, very rarely with focal neurological deficits. Going to the next question, going to the CZD, which of the following is the most specific test for diagnosis of newer variant of CZD? History and examination, MRI, 1433 protein in CSF, or EEG pattern? Please vote. Again, a simple question, relatively simple question. Okay, 45% people say it is 1433 protein in CSF, 18% patients say MRI, 27% say EEG, and history 9%. The correct answer actually is MRI pattern. MRI abnormalities showing pulvinar sign on FLAIR images are seen as 80% sensitivity and 95% specificity in the given clinical setting. The sign can disappear after a few months, unlike MRI changes of sporadic CZD, where you get this cortical ribbing, which can persist for a very long period. Remember, we are talking here about newer variant of CZD. The sensitivity of CSF protein 1433 is only 20%, and it is a very non-specific test. It is just a marker of neuronal degeneration. So many times people ask that they want to do 1433 protein in CSF, the test is not available. You need to send the sample to USA, but it is not needed. Remember that it's a test which has got a very poor sensitivity and it's a non-specific test. And of course, CSF you usually would not do as a test in these patients. EEG may show abnormality, but the characteristic EEG abnormality is not seen with NVCGD, it is more with sporadic CGD. So remember, the most important test for the diagnosis of newer variant of CZD is probably doing MRI. We are talking about newer variant of CZD here, not the sporadic CZD. Again, a little tricky question. Please get ready. All the following tools can differentiate between newer variant of CZD from sporadic variant of CZD except brain biopsy, MRI brain, age groups, and EEG. A little tricky question. Please vote. So which tool is not able to differentiate? 64% people say age group and 36% people say the EEG abnormality. But the correct answer actually is brain biopsy. The question, you see the question, which one can differentiate, which one cannot differentiate. So actually the MRI is the brain biopsy is the one which cannot differentiate between sporadic versus newer variant of CZD, because the immunohistochemistry as well as H&E of both these diseases is same. It would show amyloid plaques surrounded by vacuoles which stain intensely with PRPSC protein in the cortical as well as subcortical gray matter in cerebellum as well as in cerebrum. So the changes are both same in sporadic as well as variant form. MRI abnormalities are different because you will get cortical ribbing as well as hyperintensities in caudate and putamen in the patients of sporadic CZD, while abnormality will be seen in pulvinar in newer variant of CZD. The EEG abnormalities of the periodic sharp waves at triphasic pattern is typically seen in sporadic CZD, which is not seen in patients of newer variant of CZD. And the age of onset in sporadic is much later, like what we see in our patients, while newer variant usually the presentation is younger. So brain biopsy cannot differentiate, while the other three conditions or other three modalities can differentiate: the MRI, the EEG, as well as the age of onset. Last question about something related to CZD. CZD we know is a disease which is associated in the part of group of what is known as rapidly progressive dementia. So this is a question about rapidly progressive dementia. Which is the most common cause of rapidly progressive dementia? Is it CZD? Is it paraneoplastic? Is it autoimmune? Or is it degenerative dementias? Please vote. %, people say it is autoimmune encephalitis, while there is equal division amongst the rest of the three. But the correct answer here is actually degenerative dementias. We know that degenerative dementias is the most common cause of dementia in general, but even in rapidly progressive dementia, most studies show that it is seen in about more than 70% of the cases of rapidly progressive dementia. CZD and paraneoplastic are less than 10% of combined causes of rapidly progressive dementia, and autoimmune would be about 10 to 15% of cases. So the commonest condition still which would cause rapidly progressive dementia is still the degenerative dementias. Next question. 5 मिनिटांनी कर एका मीटिंग मध्ये 5 मिनिटांनी. Okay, so now we are talking about leprosy. All of the following are seen in possibacillary leprosy except 4 skin lesions. No FB seen in the skin biopsy. Pure neurotic leprosy or PNL, or none of the above. Again, a little tricky question. Which is not seen in possibacillary leprosy? Okay, probably people have not understood the question. I don't know. The correct answer actually is pure neurotic leprosy. The definition of possibacillary leprosy says that 1 to 5 skin lesions, so less number of skin lesions, without any demonstrable presence of bacilli in the skin smear. So you do a biopsy, you do not see anything. So this is PB. While multibacillary leprosy would include more than 5 skin lesions, or pure neurotic, or any other form of nerve involvement, or demonstrable presence of bacilli in the slit skin examination, irrespective of the number of skin lesions. So if you have any of these three, more than 5 lesions, presence of bacilli in the biopsy, or nerve involvement, or a pure neurotic kind of disease, it is still multibacillary leprosy. Talking about again leprosy and the neuropathy, all statements about late onset leprosy neuropathy are true, except it occurs many years after previous leprosy treatment, commonly painful, treated with MDT, and nerve biopsy is the gold standard for diagnosis. Please vote. Those who have attended probably would know it, or those who have seen these cases would know it. Okay, 2/3 people say it is commonly painful, while rest are broken in other two. The correct answer is treated with MDT. So remember that late onset leprous neuropathy. This is not the pure neurotic leprosy that we're talking. We're talking about late onset leprous neuropathy. It's a disease which comes late, maybe 40 to 50 years old people, many years after a previous leprosy treatment. Usually it is a mononeuritis or mononeuritis multiplex. Unlike the typical leprosy, this may be an ataxic neuropathy. There may be a glow and stalking pattern. It is a painful neuropathy. Remember, unlike the leprous neuropathy, which is not painful, this is late onset leprosy. This is a different neuropathy. Nerve biopsy is a gold standard, and the treatment here is not giving the anti-leprosy drug, but the treatment here is to give immunosuppression and immunomodulation. So this is an immune-mediated neuropathy as a reactivation from the previous leprosy disease. Okay, next question. Again about leprosy. If you have a patient who is suspected having leprosy, or which of the following is true? Anesthetic skin patches are usually present in the people of pure neurotic leprosy. Deep tendon reflexes are usually preserved. Compression of the superficial branch of the radial nerve would result into Wattenberg syndrome due to involvement at anatomical snub box, and temperature and position sense usually are affected early. Again, a little tricky question, but if you read it carefully, you can answer this. Which is correct? True. And indeed, 50% people say deep tendon reflexes are preserved, which is indeed a correct answer. You see the question again. So anesthetic skin patches are usually not seen in pure neurotic leprosy. Because it's a pure neurotic, there are no anesthetic skin patches. Deep tendon reflexes are usually preserved. We know the superficial branch of radial nerve is not compressed in the anatomical snub box, but it is compressed on the dorsoradial aspect of the hand, so little posteriorly. And temperature and pain sense is usually decreased, and the vibration position sense is frequently normal. The question had said temperature and position sense. So the correct answer is deep tendon reflexes are usually preserved. Okay, moving away from leprosy to the next group of lecture that we heard. So let's talk about HIV. Simple question. All of the following cause neuropathy except diadenosine, zalcitabine, efavirenz, and stavudine. A very simple question. Probably 100% people would answer this. Okay, 58% people had voted correctly. The neuropathy is caused because of the drugs which are called as so-called D drugs, diadenosine, zalcitabine, and stavudine. These are the drugs which are NRTI group of drugs. They are known to cause a painful neuropathy, which is similar to a distal symmetrical sensory neuropathy of HIV. It's a very difficult neuropathy to differentiate between the drug-induced neuropathy and disease-related neuropathy. The only way to differentiate is once you stop the drugs, the progression of the disease as well as the pain would reduce 8 weeks after you stop the medicine. If it doesn't, then probably it is a disease-related neuropathy, not the drug-related neuropathy. So we know now that these drugs are rarely used because they can cause a very bad neuropathy. You need to use other drugs. So don't use these NRTI groups of medicines, especially if you have a patient of neuropathy. Next question related to HIV. Again, a simple question. Which all of the following are treatment options for CMV except ganciclovir, foscarnet, cidofovir, and ritonavir? Again, relatively simple question. Those who treat CMV disease, they would know this answer. And the correct answer is ritonavir, which is indeed a correct answer. The drugs which typically are used is ganciclovir as a first-line drug, foscarnet as a second-line drug, cidofovir as a third-line drug. Ritonavir is not a drug which is used for treatment of CMV. It is used for the treatment of HIV. And you must be knowing that there was a trial in the treatment of COVID also, which has failed, which was published in New England Journal. So ritonavir is antiviral for HIV, not for CMV. Okay, now we are going to malaria. Which of the following is not observed in malaria-specific retinopathy? Retinal whitening, papilloedema, retinal hemorrhage, and macular star, which is not seen in malaria-specific retinopathy. The correct answer indeed is macular star. Macular star is a condition which is not seen with malaria-specific retinopathy. So malaria-specific retinopathy is a fairly specific disease for the diagnosis of malaria in the endemic areas. The neuropathy has the retinopathy has multiple findings. The commonest findings which are seen are the vessel changes, retinal whitening, papilloedema, and retinal hemorrhage. I was discussing with one of the neurologists from Sudan, and she said that they diagnose malaria just by looking at fundus. And the fundus findings are so classical that people who are working in this endemic area can diagnose cerebral malaria, but just looking at the fundus of the people. Macular star is not a finding of malaria-specific retinopathy. It is seen in neuroretinitis, and the multiple condition can cause neuroretinitis. One of the conditions which can cause this is cat scratch disease, which is a different disease altogether from malaria. Okay, one more question on malaria. Which is a drug of choice in severe falciparum malaria in the first trimester of pregnancy? Is it parenteral chloroquine? Is it IV artesunate with doxycycline? It is only IV artesunate, or whether it is IV quinine? Please vote. We are seeing less and less malaria nowadays, so these are difficult questions to answer sometimes, because in urban area the malaria has become much and much less common, especially cerebral malaria. The correct answer actually is IV quinine. The first trimester, the drug of choice is IV quinine. In the second trimester, one can use artesunate as well as clindamycin. But quinine is the first, the age-old quinine still remains the drug of choice in the pregnancy with cerebral malaria. One more question about cerebral malaria. WHO definition of cerebral malaria includes all of the following criteria, except patient who cannot localize to painful stimulus, so GCS is less than 11, has peripheral asexual falciparum parasitemia, there is no other identifiable cause of encephalopathy, or elevated CSF lactate levels. Please vote. Okay, there is a 50-50 division between two. The correct answer actually is elevated CSF lactate level. The definition of WHO says that patient who has encephalopathy, there are falciparum parasitemia, which is seen in the periphery, and then of course there is an identifiable cause for encephalopathy. CSF is not required to make a diagnosis of cerebral malaria. Remember, the malaria is diagnosed by looking at the patient as well as looking. Okay, next question. This is a question about what we heard just now. So which amongst the following is CDC category A bioterrorism associated disease? Variola vera, Q fever, Nipah hemorrhagic fever, or A and B? We just heard this in the lecture about half an hour or 1 hour back. Please vote. So correct answer actually is variola vera. If you see the criteria which was shown to us, it is the category A has variola vera, it has anthrax, it has got Yersinia, it has got tularemia, and it of course got other flaviviruses like Ebola, Marburg, etc. Q fever is not here. Next question about bioterrorism, which is not considered a potent or potential bacterial agent for bioterrorism or biological warfare? Yersinia, Nocardia, Streptococcus pyogenes, Brucella, or Bacillus anthracis? Please vote. The correct answer actually is Nocardia. Streptococcus pyogenes still can be an agent. So these are the various agents which have been described. Bacillus anthracis, Brucella. We can have Clostridium. We can have Rickettsia. But Nocardia is not considered to be an agent, selective agent. Of course, Streptococcus can also be an agent here. Next question. Which antibiotics are useful as a treatment for Bacillus anthracis? So which drug can be used in the treatment of anthrax? Ciprofloxacin, doxycycline, clindamycin, or all of the above? Please vote. The correct answer actually is all of the above. So anthrax actually is a bacillus, or it is a bacteria which is very easy to treat. It can be treated by giving simple drugs. So treatment regime for treatment of anthrax actually is to give ciprofloxacin to start as an IV drug, or doxycycline plus clindamycin. And post-exposure, of course, one can use again ciprofloxacin, one can use doxycycline, or one can use amoxicillin. And the treatment is usually given for a period of 2 months. Where initial treatment is given with the injectable drug, later the treatment is given by oral drugs. Of course, one can also use rifampicin instead of clindamycin in the treatment. So anthrax can be treated by giving these drugs. Okay, talking about the interleukins, which of the following cytokine has a potent neutrophil attractant property? Little difficult question. If you heard the lecture, maybe you would know. Interleukin 1, interleukin 8, TNF alpha or TNF beta, which has got neutrophil attractant property. So equal division in all. The correct answer actually is interleukin 8, which is also called as monocyte. It is also called as monocyte derived neutrophil chemotactic factor, neutrophil activating protein 1. It is a potent chemoattractant effect on neutrophil. So interleukin effect on neutrophils. Next question. Which cytokines can augment seizures in patients? Interleukin 1, TNF alpha, both or none? Which can increase seizures in a patient? Please vote. Which are pro-inflammatory or pro-seizure cytokines? The correct answer is both. So both TNF alpha as well as interleukin can trigger seizure. So if the patient has got seizure, these are drugs which can worsen in a patient who has underlying sepsis or other similar disorders. Okay, now we are talking about tuberculosis. Which of the following, which of the following is not a of vision loss in CNS tuberculosis? Optochiasmatic arachnoiditis, neuroretinitis, INS toxicity, or raised ICP. Sorry for the spelling mistake. It's a raised ICP, which is not the cause for vision loss. The correct answer indeed is INS toxicity. We know that vision loss is very common in CNS tuberculosis and the causes can be multiple. It can be optochiasmatic, it can be optic neuritis, there can be neuroretinitis, choroid tuberculosis, ethamitol toxicity, raised ICP leading to papilledema, leading to secondary optic atrophy, and even vascular strokes involving anywhere optic pathways can lead to stroke, vision loss. But INS is not a cause for vision. Next question. Which feature is false for caseating tuberculomas with liquid core? So we are talking about caseating tuberculomas with liquid core. It shows lipid peak on MR spectroscopy. It has got hypointense center with hyperintense rim on T2-weighted MRI. There is a diffusion restriction in the central core, and there is a rim enhancement on contrast, which is not correct. Please vote. Little difficult question again, but those who have no would answer the question properly. Okay, again a broken house. The correct answer actually is hypointense center with hyperintense rim, and I'll talk about this. So tuberculomas, we know they can be discrete or they can be coalescent. There are two types. There is of course homogeneous or rim enhancement. So enhancement is well known in tuberculomas. There are two common types: caseating, which is with liquid core, and non-caseating tuberculomas. So they typically would show lipid peak on MR spectroscopy. So lipid peak is a common finding. Tuberculous abscesses are large, thin-walled, multiloculated, and they show restricted diffusion on diffusion-weighted MRI. So the caseating and non-caseating, there may be abnormalities. Caseating tuberculomas with liquid core, on T1 they are hypo, on T2 they will be hyper with hypointense rim. So they are hyperintense with the rim which is hypointense, and there is of course a post-contrast rim enhancement. Solid caseating granulomas, the center is usually either iso or hypo, and on T2 the center may appear iso or hypo with an iso or hyperintense ring. So unlike caseating, where the center is hyperintense because of the caseation, the solid tuberculomas can be iso or hypo, while the non-caseating tuberculomas are hyperintense on T2, and there is a homogeneous enhancement. Unlike the other where there is a rim enhancement, the non-caseating would show a homogeneous enhancement. That's how you can differentiate between caseating, solid or non-caseating tuberculomas. Next question. This is about MDR tuberculosis. So which of the following is true about drug-resistant tuberculosis? Treatment duration is 12 months. High-dose rifampicin is used as a first-line treatment. All oral formulations are used in the treatment regime during intensive phase, and intensive phase lasts for 6 months. Please vote. Which is true about drug-resistant tuberculosis? Many of us are seeing now MDR-related CNS tuberculosis. It's a little difficult disease to manage. 50% say treatment duration is 12 months, which probably is not a correct answer, because even in CNS tuberculosis, which is because of sensitive drugs, many of us tend to treat for more than 12 months. The correct answer is intensive phase lasts for 6 months. So intensive phase usually would last for 6 months. The continuation phase, which is in addition, would last for 12 to 18 months. So treatment may go for anywhere between 1.5 to 2 years. The drugs which are used would include one injectable, which is usually an aminoglycoside, one fluoroquinolones, and at least 3 of the other drugs, which is pyrazinamide and or ethambutol, cycloserine, ethioaminoid, linezolide, clofazimine, or other agent like PAS, bedaquinine, imipenem, meropenem, amoxicillin. So one would use 5 drugs here, one aminoglycoside, one fluoroquinolones, and 3 of the other drugs. That's the treatment of MDR CNS tuberculosis. It's a very difficult disease to manage, and the mortality is extremely high. In my opinion, it reaches almost 100% if there is MDR CNS tuberculosis. Okay, couple of questions. Sripath, can I have 2 more questions before I stop?
Yes, yes.
Okay.
It's going very well.
Okay. Which one is not the cause of, which one of the following does not cause brainstem involvement? Rabies, listeria, chikungunya, and dengue. Please vote. Sorry for the spelling mistake. Which will not cause brainstem involvement? 44% people vote for dengue, but the correct answer actually chikungunya. You see, the brainstem involvement is seen in many disorders. The common condition where there is a brainstem involvement is rabies, listeria, enterovirus 17, Japanese encephalitis, West Nile, and dengue can also cause brainstem involvement. But in chikungunya, you usually don't get brainstem involvement. Chikungunya would usually present with multiple diffusion-weighted infarcts or diffusion-weighted lesions, which are usually seen in supratentorial compartment. And last question. What is the cause of morbidity in Bihar encephalitis? Again, sorry for the spelling mistake. Is it a viral disease or viral encephalitis? Is it hyponatremia? Is it hypoglycemia or is it sepsis? Please vote. Last question. And indeed, 80% people vote for hypoglycemia. So these are the winners. I think Advaita had won last time also. So congratulations, Advaita. You again win here. Then we have Pri, who is here. Datta Nadgir. Congratulations, Datta. Praveena and Vaishali. So these are 5 winners of this quiz. So congratulations, all 5 of you. And the hardest question of was the CZD question, where the brain biopsy was an answer, which 0% people could answer. So talking about just, let me just show the last slide about Bihar encephalitis. I think the slide has, yeah. So basically it is, we know that it is because of lychee that you get this Bihar encephalitis. The lychee contains a compound which is called a hypoglycin A, which is a culprit. So children, when they consume this lychee, they skip the night meal and that leads to hypoglycemia and they die because of hypoglycemic encephalopathy. So the cause here is not any viral infection, but it is because of hypoglycemic encephalopathy. So I think I'll stop here. Thank you very much.
Fantastic. So I think the quizzes are very useful as the individual lectures. And at the end of that particular session, in half an hour or so, it gives PG the idea as to what is the scope of that particular subject area and how much you have to prepare. I think infections was the most diverse. I've been through all the quizzes that are organized by FINE, but I thought this was the most difficult because for every infection you needed different level of reading and understanding, and that was really useful. Anything all 3 of you wanted to add? So a lot of reading PG should do. So far as
indeed. I mean, infection is a disease which is an Indian disease. I mean, when you're studying, you must know about infection. When you're treating, you must know about infection. And of course, it is an disease. Every year you hear new infections, you hear newer viruses, newer drugs, newer agents, and newer approaches. So you must be on your toes when you're seeing infection. You'll see a lot of surprises in the images, probably in the exam, and then you go in your practice.
Absolutely. Amit and Aditya, you want to say something to the PGs?
Infection is a really diverse topic, but actually I should say we people are very lucky to see this and understand. Mostly the people from outside India do not get a chance to see and learn. They rather learn from the books. So whenever you see a case, just make sure to read it up, just make sure to understand how it has to be treated and how it has to be followed up and what are the complications that may happen, and we should anticipate it. So India is a great place to learn infections. Sadly, yes, it's a great place to learn infections. We should spend more time on it.
Absolutely, absolutely. Thank you all of you for helping me out with such difficult areas and making today's session very useful. Thank you very much, and good night, everybody. Thank you, Amit. Thank you, Dr. Kulkarni.
Thank you. Good night and enjoy your dinner.